Yes, sir.
The presentation కనబడటం లేదు.
Presentation, Ashir గారు presentation upload చేస్తారా?
షేర్ చేయాలి.
ఓకే, శ్యామ్ గారు షేర్ చేయండి.
ప్రెజెంటేషన్ కనబడటం లేదండి ఇక్కడ.
షేర్
I will introduce you, sir.
ఓకే.
Good evening, all. A warm welcome to the APOS Oculoplasty webinar series by Dr. Subramaniam, sir. Today's topic is evaluation of a case of proptosis. So, with this introduction, I would like to invite Dr. Subramaniam, sir, to continue the session.
Nice. Thank you, Dr. Shyam. So, I think for the postgraduates, proptosis is very important for the simple reason that usually a case of proptosis will be a long case, most often than not, especially for MS. And since there are no diploma seats now, and all the seats are MS, so I think you have to pay a little more attention for this presentation because this should help you in the long run. Another thing is, I'm trying to present it the way you will be presenting in the examination. In that format, I have made this preparation so that it should help. So with this little introduction, I'm starting the presentation of evaluation of a case of proptosis. First, you have to know the relevant applied anatomy of the orbit. There are 4 surgical spaces in the orbit. Orbit, as you are aware, is limited by the 7 bones that form the orbital walls. So, it harbors the eyeball, and it has so many tissues like nerve tissues, it has muscles, it has blood vessels, it has lymphatics, it has glands, and so many structures. So that pathologies involving all these structures can cause proptosis, which is primarily a case of orbital disease presenting as proptosis. At the same time, pathologies elsewhere can also extend into the orbit and can cause secondary proptosis, and orbit may also be a location for metastasis. So what are the 4 surgical spaces? The subtenon space, subperiosteal space. These are potential spaces that are not very huge in size. Subtenon space is the space between the eyeball and the tenon's capsule, whereas the subperiosteal space is the potential space between the bones and the periosteum covering it. Then the space is divided into 2 huge spaces. They're the peripheral space and intracornal space by the extraocular muscles and the septum or connective tissue. There's an intermuscular septum connecting all these 4 extraocular muscles, so that the one which enclosed within the muscles and the connective tissue, intermuscular septum, and comprising of the optic nerve is the intracornal space, and lesions here can compress on the optic nerve, leading to visual disturbances. And also they can flatten the posterior pole of the globe, leading to hypermetropia as a refractive error. Whereas the space that is between the muscles and the periosteum, that is called the peripheral surgical space, which can be divided on its location to the superior, medial, inferior, and lateral spaces. And the lateral space, you have the lacrimal gland. So, the lesions that are present here, the space occupying lesions that are present here, will push the globe to the opposite side, causing eccentric proptosis. Whereas the lesions in the intraconal space will push the globe straight forward, leading to axial proptosis. Similarly, lesions in the peripheral space usually compress the globe, leading to an elongation of axial length, and which causes astigmatism. Is the refractive error that is usually caused by lesions in the peripheral surgical space. What is proptosis? Proptosis is protrusion of the eyeball. Just like kurtosis, where there is another thing called pseudotosis, for proptosis, we would like to exclude pseudoproptosis. High myopia, axial myopia, usually congenital myopia, which is usually unilateral. The eyeball is longer, bigger, and it protrudes out and can present as a pseudoproptosis. It's fairly common. Here you can see the patient with lid retraction and proptosis are a very prominent right eye, looking like as if it's a case of thyroid orbitopathy with lid retraction and right eye proptosis. But it's actually a case of Bell's palsy of the right side. And also there is a bit of a lid retraction left side also. And there is a severe lag of thalamus and corneal involvement, and the mouth and everything got deviated. It's a typical case of Bell's palsy, which can present as pseudoproptosis. Unilateral minimal ptosis, if the patient thinks that that is normal, the other eye appears a little prominent, and patient comes fairly good number of times. I have seen patients complaining that the normal eye is prominent and think that it is proptose, whereas actually the other eye, which he felt normal, has minimal ptosis. Similarly, pseudotosis can be seen in ophthalmos and lid retraction, as you see here. So in the case history, hitting the case sheet, so these are the normally we routinely take the details. Name, it's always better to write the full name, and the importance of name is for identification, and full name is better to write because there are so many patients with the same name. I know, right, but the surname differs. The initial of the surname can also be the same. So you write the full name, including the family name. Then age, the gender, family history, systemic health, how it is, and also any known drug allergies, which is a must for every patient you have to record, and previous surgeries and outcomes, and whether there is any problem with general anesthesia previously, because more often than not, orbitotomies, orbital surgeries we perform usually under general anesthesia. So we would like to know if the patient has underwent surgeries previously under general anesthesia for any other disease, how it was, whether it was smooth, the recovery was smooth or not. or whether there are any complications because of general anesthesia. The importance of age. Now, if you look at the causes of proptosis, there are certain differences depending on the age group. Among children, the more common ones are congenital lesions associated with shallow orbits like stenosis and shallow craniostenosis and other things, where the orbit can be shallow and the eye can be prominent. Then round cell tumors are quite common. The lymphomas, rhabdomyosarcomas, and also retinoblastomas, other things. Infections are also quite common. Cellulitis, orbital abscess are fairly common among children. Similarly, with parasitic infestations, capillary hemangioma, dermoid, rhabdomyosarcoma, lymphangioma, optic nerve glioma. These are the common lesions of proptosis among children. Where among adults, the most common cause is thyroid orbitopathy, followed by so many other things like inflammatory lesions like idiopathic orbital inflammation or non-specific orbital inflammatory syndrome, benign tumors coming from various structures, lacrimal gland tumors, vascular lesions, cavernous hemangioma, meningioma of optic nerve sheath, and malignancies. We would like to know whether the proptosis is unilateral or bilateral. The most common causes of bilateral proptosis among children, that's the pediatric age group, are congenital lesions, lymphomas, and leukemias. Whereas among adults, the most common lesion is the thyroid orbitopathy, which accounts for nearly 80% of bilateral proptosis among adults. The other things are non-specific orbital inflammatory syndrome, lymphoma, and cavernous sinus thrombosis. Cavernous sinus thrombosis. Sex prevalence. Thyroid-associated orbitopathy is more common in females. Cavernous hemangioma is more common in females. So there are certain diseases which are more common in specific genders. That is the importance of knowing the gender. And also the severity or course of the disease can sometimes dip, especially in thyroid-associated orbitopathy. It depends on the gender. And as I said, this is the most common cause of both unilateral as well as bilateral proptosis. So optic nerve compression in thyroid-associated orbitopathy is more frequent in males. So the gender males is an important risk factor for the development of compressive optic neuropathy. Similarly, here we have to talk about the age. Elderly age is also very important to know because in TAO, thyroid-associated orbitopathy, elderly patients, both males and females, are at a risk of developing compressive optic neuropathy. So elderly age is again an important major risk factor. Is the proptosis recurrent? That you would like to know. And the important causes are idiopathic orbital inflammation, orbital varix, myocysticercosis, and more important, more common is lymphangioma. Evaluation of proptosis coming to it. Crowell's profess 6 P's: pain, progression, proptosis, pulsations, periorbital changes, and palpation. The other piece that I have added are pupil, prism bar cover test, and pressure IOP, which are also important. So among these, pain and progression are in the history. Proptosis, pulsations, and periorbital changes are by way of inspection and palpation. Okay. But I would like to go more the way you present instead of sticking purely to the 6 piece or 9 piece. Okay. Coming to the presenting symptom. The important three are onset, pain, and visual symptoms. Onset, is it acute, subacute, chronic, or recurrent? Pain, whether it is present or absent. Visual symptoms, the most common ones are defective vision and diplopia. Is it present since birth? If it is present since birth, there are only two conditions that are very commonly present. The most important, apart from the syndromes, the most common one is neurofibroma. This child, where I operated at the age of 5 months, it's turned out to be a case of neurofibroma, pre-op and post-op pictures that you were able to see. Now coming to the onset, there's a progression. Acute is 1 week. So if the patient comes within a week of the starting of the problem, it's called acute presentation. It is usually because of infections like cellulitis, abscess, which are very painful and makes the patient come to the doctor as early as possible. The second are inflammations, especially idiopathic orbital inflammation, or an acute thyroid disease, or parasitic manifestations occasionally. Then trauma and malignancies, especially metastatic, which have an acute presentation. The subacute is from 1 week to 1 month after onset of the problem, the patient comes to you. So if the history is about 2 weeks or 3 weeks long, less than a month, but more than a week, it is subacute presentation. The common things are parasites and again malignancies. Here you can see a patient with severe pain, redness, a little bit of motility restriction elevation, and severe chemosis that you can see here because of is the case of orbital cellulitis. And here is a patient with subacute presentation with fairly severe proptosis, congestion, and all these problems. It's case of metastasis. So, to be honest with you, what makes you the patient come to the ophthalmologist or orbital surgeon is pain. Chronic, it's more than 1 month, the disease duration may be. So the common things are benign tumors like a cavernous hemangioma, where the history may be 1 to 2 years or even more. Similarly, schwannoma, glioma of the optic nerve, meningioma, etc. Or thyroid orbitopathy, as long as there is no inflammation and pain and there is no optic nerve compression, usually the patient has a chronic presentation. Similarly, orbital varices. Because all these structures, all these lesions are painless, the patient is fairly comfortable, may not, and if they are slowly progressing, he may not be worried much about the proptosis. Here you can see a young child with severe axial proptosis, and the CT scan shows a huge mass which we have removed with lateral orbital. This is an optic nerve glioma with cystic degeneration. This is a postoperative picture, and the patient has no PL, since the glioma is extending almost into the orbital apex, I could remove the entire mass from the just behind the globe to the posterior angle. Remissions. As I said, remissions, if the patient has history of regression and coming back again, the most common and important lesion that you have to remember is lymphangioma, especially among younger individuals and children. Then in the endemic areas, myocystic sarcosis, orbital varices depends usually on the posture. Whenever the patient sleeps in the prone position or if he bends, the proptosis may worsen, and in the normal position or supine position, it may regress and the patient may be comfortable. And the other thing is non-specific orbital inflammatory syndrome or idiopathic orbital inflammation. Here the CT scan shows an enlarged superior rectus LPS complex with a cyst here and a hyperdense lesion in the center of the cyst, which is the scolex. It is a case of myocystic sarcosis involving the superior rectus. Pain, it is the symptom of infections, inflammations, infestations, and if there are bony erosions. In these situations, there will be severe pain, and usually the presentation is acute to subacute in these conditions. If it is a bony erosion, it may be a little delayed. The pain may occur only after there is a bony erosion. So the patient may give a little bit of a chronic history, 6 weeks or 8 weeks, but otherwise, infections, inflammation, and infestations, parasitic, the presentation is usually acute or subacute. Here, this young girl, you can see the pain on her face, has a proptosis with the eyeball pushed down with a fullness in the superior space, and this is because of orbital cellulitis. Here, this young child, female girl, has severe pain, protrusion, proptosis, severe chemosis, congestion. The cornea is showing exposure keratopathy here, as you can see, and a severe fullness, and the CT has shown an abscess with an enlarged in the inferior half. There is severe infiltration, and there is an abscess with a cystic cavity. It's going almost nearing the optic nerve, and this is because of an abscess, which is because of retained foreign bodies. We did an orbitotomy, removed these foreign bodies, and the patient has recovered well and regained vision 6/6. It's a case of an orbital cellulitis with severe edema, chemosis, and proptosis. You can see that the eyeball is, the movements are restricted. When the patient is looking to the right, the left eye is not moving. It's in the midline only. There is severe pain, and it's a case of an orbital cellulitis which has responded very well to intravenous antibiotics and anti-inflammatory drugs, oral, systemic, and the patient has responded within 2 weeks. She was like this, and the movements have been restored. One word of caution here. If you make a diagnosis of orbital infection, orbital cellulitis, or preseptal cellulitis, you please ask for a CT scan, whether the patient is young or elderly. The importance of CT scan is twofold. Number one, the CT scan shows or tells us whether it is cellulitis or whether the patient has gone into an orbital abscess. If it is an orbital abscess, surgery is required to drain the abscess. It will not subside with systemic medical management or intravenous antibiotics. So if it is a cellulitis, it can respond to IV antibiotics and surgery may not be needed. Number two, there are masculaders which mimic orbital cellulitis, like a rhabdomyosarcoma, a retinoblastoma, these tumors can mimic an orbital cellulitis. So, by taking a CT scan, you are making sure that you are not missing a tumor, because the treatment depends on the cause. If it is an orbital cellulitis due to a tumor with orbital extension, you have to go for a chemotherapy, establish the diagnosis, go for a chemotherapy. After a chemo reduction, probably you may be doing a exenteration or extended enucleation and continuing the chemotherapy and taking care. So the treatment depends on what is the pathology, and to be sure about the exact pathology, CT scan is a must for every suspected case of orbital cellulitis. Here is a patient with a severe proptosis, bit of redness, swelling, extending onto the cheek and temporal region. The CT scan shows an abscess here, which has been drained. You can see the pus, and the patient has recovered very well, and his vision is 6/6. He is doing very great. Pain could be because of inflammations, apart from infections and or it could be in non-specific orbital inflammatory syndrome or myocystic. Here you can see a young girl who is in her teens, presented with proptosis of the left eye with minimal restriction of elevation, and you can see there is so much of a congestion, and there's a little bit of fullness, and the CT scan shows an inferior rectus which is enlarged with a cyst and a scolex, which is also seen fairly well with B scan. For a cysticercosis, my routine is I'll ask for a CT scan, because number one, it establishes the diagnosis. Number two, it tells whether the brain is also affected or not. If it is a neurocysticercosis involving the brain with a couple of cysts in the brain, probably I refer the patient to a neurologist for albendazole treatment, because occasionally the patient may go into convulsions. If it is a purely orbital one, I will treat with albendazole systemic at a dose of 15 milligrams per kg body weight, plus prednisolone at a dose of 1 to 2 milligrams per kg body weight. So the response is excellent most often, almost all cases. I think they have responded very well. So if you want to follow up, you can follow up the cases later, not with CT scan, which is expensive and which the patient is exposed to radiation. You can follow it with B scan, as you can see here, where you can see the cyst and the scolex very well. Here is another case of proptosis with severe ptosis, fullness, and pain. You can see the congestion, and the CT scan has shown a hugely enlarged LPS superior rectus complex with a cyst and scolex, which is also demonstrated in the B scan. You can see this scolex so nicely, and this is the coronal section of the CT scan showing a hugely enlarged LPS superior rectus complex with a cyst inside, and the anti-cysticercosis antibodies are positive in there. It will be positive about 60 to 70% only, and the patient has been put on albendazole at a dose of 15 milligrams per kg body weight in 2 divided doses per day, plus prednisolone at a dose of 2 milligrams per kg body weight, and within 2 weeks, the patient has responded very well. Pain could be due to intraorbital space occupying lesions. The malignant ones were retinoblastoma, as you see here with a orbital extension, a case of rhabdomyosarcoma, lymphoma, And among the benign lesions, it's lymphangioma and dermoid cyst. Lymphangioma, there will be a sudden bleed into the lesion so that it expands suddenly, leading to an acute proptosis with severe pain. Similarly, if a dermoid cyst ruptures, the contents can cause irritation, can cause inflammation, and can cause pain. As long as the cyst doesn't rupture, cyst wall doesn't rupture, it is painless. But when once the dermoid cyst wall ruptures due to whatever may be the reason, it can lead to an inflammation and pain. Here is a case of lymphangioma in a young girl, acute in onset. You can see proptosis with the eyeball pushed down, severe chemosis, congestion, subconjunctival hemorrhage, and the CT scan shows a huge mass with severe bleed into the cystic space with bleed into it. So it is about long back, 15, 20 years back case. So at that time, there's no bleomycin. So what? Surgery is the only option. And when the vision is compromised, still now surgery is the option. So we did a orbitotomy, a lateral or anterior orbitotomy. So from the huge cyst, I have aspirated about 5 ml of blood. I did a subtotal excision. It's very difficult to entire tumor cannot be removed. It's very difficult because it's infiltrative nature. It will be around the muscles or around the optic, or in this case, around the muscle. So I could not remove the entire tumor, but the patient has recovered very well and regained normal vision. And she was fine for a long time. I lost her for long. Pain can be because of trauma. Trauma can cause proptosis in various ways. Immediately, there could be a retrobulbar hemorrhage. If the retrobulbar hemorrhage is severe, it can cause proptosis. It can compress the optic nerve. One important thing that one has to remember is that if there is a retrobulbar hemorrhage and the eyeball is coming forwards, causing proptosis, for heaven's sake, please don't apply a pad and bandage. The forward movement is in a way to reduce the increased intraorbital pressure, which can compress the optic nerve. It's a defensive mechanism. If you put a pad and bandage and prevent that, the intraorbital pressure can go up very high, compress the small vessels of the optic nerve, and can cause loss of vision. In such situation, first you look for a RAPD, you see the orbital pressure, palpate with the retropulsion. And if you think that it is tense, you do a lateral canthotomy and under local anesthesia immediately and pass the syringes with, artery forceps above and below from the lateral side and try to drain the blood out and put a small pad, cotton pad, at the lateral orbitotomy incision. Don't in front of the eye, so that any further bleed is taken care of and it gets absorbed by the pad. And after 2 days or 3 days, you can close the orbitotomy. That is what you have to do. If there's a retrobulbar hemorrhage for any reason, don't put a pad and bandage. If necessary, do a orbitotomy. So this is a case of severe retrobulbar hemorrhage, traumatic, for which I have evacuated the bleed, and that's how the patient was recovering. If you look carefully, this patient had punctate keratitis because of exposure, corneal erosion, and very severe proptosis with a visual acuity 6/24. And after surgery, she regained vision 6/6. Here it's a case of hematic cyst, 2 weeks following trauma, for which I have drained the cyst, and the patient has recovered very well. Surgical emphysema is another cause, especially when there is a small fracture of the sinuses, so that the air from the sinus can enter the orbit, can get entrapped. You can just feel it, and if you see the surgical emphysema, there will be crackling sounds. You can feel when you apply pressure over it. So when there is surgical emphysema, normally it doesn't require to do anything. Only thing is put the patient on antibiotics because there is a communication with the sinus and which can sometimes lead to infection. Then if necessary, compress it, and if it is very severe, put a needle, 18 gauge needle into the orbit, remove the syringe, and then just apply pressure so that the air will escape through the syringe. Then put the patient, ask the patient not to blow the nose for about a month. Okay. Another important thing is carotid cavernous fistula, which can lead to proptosis. The first three lead to proptosis fairly early after trauma, whereas carotid cavernous fistula takes a couple of months to cause proptosis. Pain, especially a dull pain posteriorly in the back space, is usually due to bony erosion, which could be because of primary malignant lesions of the orbit or secondaries in the orbit or metastatic lesions. Here you can see a lady, fairly probably in the third decade, with a fullness more on the lateral side, eyeball pushed down and in. CT scan shows a mass with irregular borders. There's the lacrimal gland CT scan with bony erosions here, and there is a loss of sensation on the lateral side of the forehead. So which is typical of adenoid cystic carcinoma. So did a biopsy, did a directly exenteration. Nowadays we are not doing exenteration. This is again a long book. This is a fairly more than 30 years back case. We did an exenteration. The patient has recovered very well. So nowadays we do excision of the mass and then refer the patient to an oncologist for radiotherapy and if necessary, chemotherapy. Usually radiotherapy will benefit them. Coming to the visual symptoms, the most important visual symptom is defective vision. And the most important causes of optic nerve compression because of tumors in the intercorneal space. The most common tumor in the intercorneal space is cavernous meningioma or cyst in the intercorneal space. The most common cyst that I have seen is hydatid cyst. More common than these two is the thyroid-associated orbitopathy with the enlarged extraocular muscles compressing the optic nerve, leading to compressive optic neuropathy or dysthyroid optic neuropathy. The other causes is severe proptosis leading to stretching of the optic nerve, which is evident as a denting of the posterior segment on the CT scan. And there could be refractive errors induced, as I said, hyperopia in axial proptosis due to tumors in the intercorneal space or astigmatism due to tumors in the peripheral surgical space, compressing and lead the eyeball in the vertical meridian and leading to lengthening of the eyeball and inducing astigmatism. Other causes are corneal pathology, especially due to exposure keratopathy, whatever is the maybe the reason for the proptosis. Severe proptosis can lead to corneal exposure keratopathy. Secondary glaucoma, which occurs in carotid cavernous fistula, or generalized orbital pressure which is increased, which presses on the vortex vein, and the tumor pressing on the vortex vein can lead to secondary glaucoma. Or it could be due to retinal pathology leading to striae, retinal edema, or even retinal detachment, or optic atrophy because of compressive optic neuropathy or tumors involving the optic nerve and causing optic atrophy. This is a picture showing apical crowding at the apex. If you look at the orbit, the medial wall is straight, the lateral wall is at 45 degrees, and so in the posterior third, the posterior third of the orbit is very narrow when compared to the anterior parts. And in a case of thyroid arthropathy, where all the four muscles get enlarged, since it is narrowed at the posterior part, it compresses in the posterior part. So this is a sagittal section showing a total compression in the posterior half to posterior half of the optic nerve. Anteriorly, it's okay. The nerve is okay here also, but the pressure is mostly the posterior half. Coronal section showing all the extraocular muscles are enlarged, compressing the optic nerve. So this can lead to, this is a case of typically thyroid orbitopathy leading to optic nerve compression. Diplopia is due to restricted ocular motility. So the diseases of extraocular muscles like thyroid-associated orbitopathy, idiopathic orbital inflammatory syndrome, or myocystic sarcosis, there will be muscle restriction leading to diplopia. Similarly, in orbital sigillitis, metastatic lesions, infiltrative lesions like lymphangioma, or a trauma leading to fracture orbit with entrapment of the muscle, there will be diplopia. If the ocular motility is restricted, we have to know whether it is because of weakness of the muscle or due to a restrictive pathology. So we have to do force reduction test. If you are not able to move the muscle in the direction of restriction with your forceps, holding the muscle belly with your forceps, force reduction test is positive, and it means that it's a restrictive pathology. So you have to do a prism bar cover test to know how much is the amount of squint, especially when you are following a patient like idiopathic orbital inflammatory syndrome, whether it is responding to steroids or not, or a thyroid-associated orbitopathy with motility restriction, what's happening over a period of time, whether it has become stable, whether it's getting worse, or something like that. And differential tonometry. So take the pressure in the primary position, then ask that is the base reading, ask the patient to look in the direction in which the motility is restricted. If the elevation is restricted, ask the patient to look up. If abduction is restricted, ask the patient to abduct and then take the pressure. And if it is a restrictive pathology, the muzzle is compressed between two tight, the eyeball is compressed between two tight muscles and the pressure goes up. If it is a paralysis, the pressure over the eyeball by the two muscles which have relaxed, two stone is much less, and the pressure will be less than the baseline base pressure. An increase in the pressure more than 80 millimeters from the baseline indicates that it is a restrictive pathology. Look at the pupil for RAPD, relative afferent pupillary defect, and do the fundus examination. For the ocular motility, what I do is instead of saying restricted, ask the patient, close the other eye, keep a torchlight at the level of the eyeball, and ask the patient to look up, look down, look to the right and the left, abduct and adduct, and see where is the light reflex, like the Hirschberg's light reflex. The normal movements or elevation is 45 degrees, other three are 60 degrees. So you quantify elevation, let's suppose is 30 degrees. Next time it may be 60 or it may be 15 degrees. So that tells you whether the motility is further getting worse or not. So eye movements are restricted. Here you can see a patient with thyroid arthropathy with the involving the medial rectus, lateral rectus, severe proptosis. Other eye also shows the involvement of the medial rectus and a very tight inferior rectus, so that the eyeball is pushed down and the elevation is not there. In these situations, if there is an exposure, the patient gets exposure keratopathy involving the superior half of the cornea. Normally, it will be the inferior half, but when the elevation is restricted, eyeball is pushed down and there is a lag of thalamus, the superior part of the cornea exhibits exposure keratopathy. So here is a case of myositis with motility restriction, abduction is restricted, and the CT scan shows enlarged extraocular, the lateral rectus, both sides, with involvement of the gland also with a contrast enhancement. Whereas in thyroid orbitopathy, the tendons are square. Here is a patient of myocystis with motility restriction. This is the reflected tendon of the superior oblique. Here you can see the superior oblique is grossly enlarged. Both here and here you can see the cyst with scolex. So this is a case of multiple cysts involved in the superior oblique, two cysts with motility restriction and pain and diplopia responded with steroids and albendazole. Here is a case of fungal granuloma with a frozen globe. You can see that the entire orbit is involved with the fungal granuloma with zero motility restriction. The patient has been referred to a physician for antifungal medication. Here is a patient with motility restriction, and in the history you have to ask history of pets. It's a case of hydatitis with a severe proptosis of 5 years duration, and total cornea is totally sloughed off, and it's a very huge vascular and leucoma and no PL. So during the surgery, you can see the huge enlarges. In these situations, what I do is I aspirate 5 to 10 ml of the fluid with a 30 gauge needle, then keep so that this is the collapsed cyst. Use a cryo to hold it and remove the cyst in toto. This is the post-operative picture of the patient 2 weeks down the lane. Under case of hydatid cyst, long-standing 1.5 years, with excavation of the bones, you can see the eyeball has been pushed down and out because of the medial situation of the cyst and compressing the cyst. You can see that it's long-standing, and even there is a bony erosion of the orbit, the frontal bone in the towards the orbital apex. Towards the orbit, the inner plate has been eroded. So this is the exposed cyst that has been aspirated and removed to the superior rectus incision. This is the first post-op today. Proptosis has been totally almost recovered from it. You had to do a general examination because here you can see the fullness, and this is a case of thyroid, but this is actually referred to me as a case of thyroid orbitopathy with proptosis. If you look carefully, the eyeball is pushed down, not axial proptosis, an eccentric proptosis, and this is because of fullness here and a lacrimal gland tumor. So it's a case of a lacrimal gland tumor in a patient having a thyroid disease. For the displacement, you have to measure the displacement with the exophthalmometry. It could be axial, which could be done with exophthalmometry, or it could be horizontal, vertical. This is called the Knapp-Seeger's test. Ask the patient to look at an object straight. You stand behind the patient and slowly bend the head backwards, and that eye, which is proptose, it's seen, it pops up forwards, whereas the eye on the normal side is not able to see. This is how you can make out that the patient has proptosis, but if you don't have any instruments. So when you are doing Hertel's exophthalmometry, you have to obstruct the or cover the unexamined eye with your thumb, and this eye you are seeing, you taking the reading through this mirror, through this prism. There will be two lines, red lines, one line here and the other here. Both you have to make them overlap. Then you can see the profile of the eyeball, and here above there will be a scale. You see the position of the profile of the cornea against the scale, and that gives you the reading. You do it with for the opposite eye also. So this is the Hertel's exophthalmometer. So this is a fixed arm, and this is the sliding arm. So this is the scale. You have two red lines. You have to make sure that both the red lines align, and then we are covering the unexamined eye with the thumb, and the profile of the cornea you are seeing against the scale, and that gives the reading. For horizontal displacement, make a dot at the center of the nose, occlude the unexamined eye, and as the patient is looking, you measure the distance from this to the nasal limbus. Do it for the other eye. The difference tells you the amount of proptosis. For vertical displacement, keep a scale. Here requires somebody's help. In line, joining both the lateral canthi and occlude the unexamined eye again. And with the help of a scale, from the scale number 1, you measure the low position of the lower limbus. That tells the vertical. Repeat the same for the other eye. That tells you the vertical displacement. Eccentric proptosis, whenever there is a mass in the peripheral surgical space, it pushes the eyeball down. So if the mass is in the, here you can see there is a proptosis with the eyeball pushed down and in. That means, sorry, this is the normal eye, this is the down and out. So this is because of the frontal sinus lesion, superior orbital lesions, and this is actually a fibrous dysplasia of the frontal bone. Here the eyeball is pushed down and in, this, and you can see a swelling here. This is the lacrimal gland tumors. Here the eyeball is pushed up. There's a peripheral surgical space. Usually maxillary sinus tumors will involve the peripheral surgical space and push. But this is here, this case is a cavernous hemangioma in the peripheral surgical space, which is pushing the globe up. Pulsations. For pulsations, you have to look from a side, not straight. Here, the pulsations could be vascular pulsations or transmitted pulsations. Vascular pulsations, that means the vessels are pulsating, commonly in carotid cavernous fistula or orbital varices. Transmitted pulsations is because of dehiscence, there is of the roof, there is a communication between the brain and the orbit, so that the pulsations of the brain are transmitted. It occurs in meningioma, neurofibroma, where the roof is absent, or loss of roof due to trauma. This is a case of carotid cavernous fistula, a pulsatile proptosis where the QE can be heard, and look for pulsations from the side, not straight or and down. Periorbital changes, pulse can also occur at transmitted pulsations, as in the case of a meningioma, sphenoid meningioma. So here you can see that there is a temporal fullness. Temporal fullness is usually seen typically in sphenoid-rich meningioma. Here you can see proptosis of the right eye, which is pulsatile with a pulsations. Here it is typically a case of sphenoid-rich meningioma. The CT scan shows a mass involving the orbit, intracranial space, and enlargement of the temporal space, and hyperostosis of the bone. If you look at the bone, compare with the other side, this bone is hyperostotic, enlarged, irregular, and this is typical of sphenoid-rich meningioma. Sphenoid-rich meningiomas could be involving the lateral side or the medial side. The lateral side, sphenoid-rich meningioma, presents with temporal fullness, whereas sphenoid-rich meningioma on the medial side, as you can see here, the intracornal component and orbital component, and the sphenoid bone, which is hyperostotic, presents with motility restriction because of the medial side, superior orbital fissure. It involves the nerves and leads to motility restriction. So here is the patient with the axial proptosis, and you can see when the patient is looking to the right, this eyeball is not moving at all with motility restriction. That is typical of sphenoid-rich meningioma medial wall. This is a case of congenital neurofibroma with loss of dehiscence of the roof here with prolapse of the mass leading to pulsatile proptosis, eyeball pushed down, and you can see that the lead is showing neurofibromatosis involvement. gingival leaf border, and also there is an orbital involvement. This child has presented with no clear and proptosis with a pulsatile proptosis with a history of trauma of 3 years duration, and the CT shows that the roof is totally lost. Brain has collapsed into the orbit, either pushing the globe down and causing a pulsatile proptosis, which are transmitted pulsations, both the fixes. Lid retraction is typically and usually seen in thyroid arthropathy, which could be unilateral or bilateral, as you see in these cases. Other important lid changes are lid lag on downgate, which could be unilateral or bilateral. There could be lag of thalamus, and it could be seen in different conditions. Here is the case of metastatic thyroid, metastatic proptosis due to metastasis from thyroid, and there is a, you can see a lid mass lesion which can have an orbital extension. For the lag of thalamus, don't look straight on here. You can't appreciate any lag of thalamus, but you have to look from below so that there is a lag of thalamus in this patient, both eyes, more in the right eye, which you are missing when you are looking straight. And here you can see very severe lag of thalamus. The eyeball lies, the cornea is totally ulcerated. You can see a big glaucoma, cornea is dry and lusterless and is involved in this patient. Both these are metastatic cancers. And if you see a mass in the lid, do a transillumination, as you can see here, you can see that its transillumination is positive. With its being, you can see in this part and here, and it's a huge cyst with the orbital extension. You can differentiate a cyst from a solid mass. In the conjunctiva, if you see a pinkish mass, it's the salmon spot, which could be at the limbus and which may be coming from the fornix, an orbital lesion coming from the fornix. And the salmon speck is typical of lymphoma. It's a diagnostic of lymphoma. Caput medullae are enlarged blood vessels all around are typically seen in the carotid cavernous fistula, and there could be a subconjunctival hemorrhage, as we see here. The subconjunctival hemorrhage may be minimal, or here is a patient with a lymphangioma or painful recurrent proptosis, acute in onset due to intralesional hemorrhage. Here you can see a subconjunctival hemorrhage. The CT shows a mass with hemorrhage, but the patient has no pain. Patient vision is normal. Just I have started a course of steroids. Since there is a cyst and it's acute in nature, I started with steroids. And after a week, this is how she was in the beginning. She came with a severe recurrent, severe subconjunctival hemorrhage and ecchymosis involving the entire lower lid with an acute bleed and the vision getting compromised. The pupil is dilated, there's RAPD. So at that time, there's no video medicine. So I did a surgical decompression. The patient has recovered well. This is 1 week after surgery. You can see that the hemorrhage, the ecchymosis is getting absorbed. There's no proptosis. The pupil became normal. The vision has been 6/6. Chemosis, conjunctival edema, is divided 3 grades. Grade 1, where it is behind the gray line. Grade 2, in front of the gray line. And grade 3, it collapses over the skin over the lid. Chemosis grade 3 in orbital cellulitis and carotid cavernous fistula. Chemosis grade 3 in the lymphangioma, as you can see here, and thyroid associated arthropathy with severe lid retraction. Ask the patient to do a Valsalva maneuver, and if after a Valsalva maneuver, the proptosis worsens, and you can see the vascular mass enlarging in size, it is typical of orbital varix. About 20 to 25-30% of orbital varix exhibit pulsation. In some, there may be loss of orbital tissue, and you can see a deep superior sulcus as you see in this patient. Cornea can get into an exposure keratopathy with SPK, ulcer, or perforation. Here is a bilateral severe thyroid orbitopathy with chemosis, high inflammatory score, and you can see the corneal opacity due to exposure keratopathy. Iris may show large nodules or tumors. This is the lesion nodule as you see in case of neurofibromatosis. Look at the pupil for RAPD, size and shape of the pupil, and look for the ocular motility. If restricted, as I said earlier, you have to do FPT. Here again, a case of lesion nodules, here one, in case of neurofibromatosis with prognosis. Fundus examination, look at the optic disc for any evidence of papilledema, optic atrophy, optociliary shunts, which are seen in about a third of meningioma, optic nerve sheath meningiomas, venous engorgements, which you can see typically in case of cataract cavernous fistula. Here is a case of optic neuritis with exudates and also macular involvement in a case of cysticercosis involving the optic nerve. Retinal striatum, this is the case, CT showing the cysticercosis involving the optic nerve. Yes, I have only one case in my entire life so far. Retinal striae, retinal detachment. For all these things, you have to do the fundus examination. Loss of sensation, you look for, especially in case of lacrimal gland tumors with eccentric proptosis, eyeball pushed down and up. Look for on the temporal side especially and the medial side. So loss of sensation in lacrimal gland occurs due to adenoid cystic carcinoma due to perineural spread. It occurs on the lateral side. So for which I have done a exenteration, as I have already said. Then you have to do the palpation. When doing with the palpation, do it with the pulp of the finger and ask the patient to look in the direction where you are palpating. That means if you are palpating the upper part, ask the patient to look up. If you are palpating the lower part, ask the patient to look down. This is because you have to make the orbital septum lax so that you can feel the orbital contents better. Okay. Then you do the retropulsion. For retropulsion, you hold the head behind with the 4 fingers and compress both the eyes backwards with both the thumbs as shown in the picture, as you can see here, and so that you can compare the orbital pressure offered by the normal side with the proptosis side. For the auscultation, which is more important, especially in the CCFs and the vascular lesions, you prefer to use the well on the globe and as well as the superior temporally. And you can definitely hear a bruit, especially in cavernous fistulas. Examine the surrounding structures. You can see that the nose is totally grossly deviated, and you can see a mass, which is a fibroadenoma involving the nose and the nasal pharynx. Here you can see fullness in the maxillary sinus with proptosis, and you can see a fullness in the maxillary sinus here in that case. So here you can see a mass in the nose in case of proptosis on the same side, and the CT shows a mass extending coming from the sinus, maxillary sinus, encroaching onto the and involving the nose and encroaching onto the orbit. Secondary proptosis because of a squamous cell carcinoma in a case of xeroderma pigmentosum with orbital extension. Here is a case of another case of so is also a squamous cell carcinoma with a huge squamous cell carcinoma of the lid involving the orbit in a patient who has been neglected so far. Here you can see that the patient has a proptosis, axial proptosis, and the CT scan shows a lesion. A part of it is in the orbit, a part in the cranium. So it is a schwannoma, intracranial schwannoma with an orbital extension to the superior orbital fissure. for which I scrubbed along with a neurosurgeon, and we removed the tumor, entire tumor, and this is how the patient has recovered after surgery. Secondary proptosis due to tumors, intraocular tumors extending is a retinoblastoma. As you can see, typically see the mass involved in the entire globe with orbital extension and calcification. With severe proptosis, the patient had underwent chemo reduction with 4 cycles, and then the patient came with a for extended enucleation. We do enucleate beyond, we don't do a total exenteration. And this is the intraocular mass and the orbital extension of the mass which has been removed. Then he continued under 3 cycles of the chemo, and that's how the patient has been rehabilitated with a prosthesis. Metastatic lesions, the previous history of the previous history of radical mastectomy for carcinoma of breast. Patient presented with subacute proptosis. The CT scan shows there is a tumor involving the lateral rectus with bone erosion, as you can see here. This is the mastectomy. So in these situations, I don't do a big surgery. I do a FNAC. The FNAC has shown that it's a case of a breast cancer, and the patient has been referred to the oncologist. Here again, this young man has presented with acute proptosis of 1 week duration with pain and motility restriction. As you see, the eyeball is not moving when the patient is doing the levo rotation. And the CT scan has shown again an enlarged mass with bony erosion. We did a FNAC. The FNAC shows typical of neuroblastoma rosettes, and the CT scan of the abdomen has shown this neuroblastoma. Patient has been referred to oncologist for further management. So as I said, orbital tumors can be a proptosis, can be a part of generalized pathology like a lymphoma, neurofibroma, von Hickling-Hassen syndrome, a xeroderma pigmentosa. A part of generalized pathology. This female, 42 years of age, history of lumpectomy from breast 6 months back, presented with a recurrent breast tumor of 2 months duration and a proptosis of 2 weeks duration, with severe pain, low PL, low hepatosplenomegaly. B scan of abdomen was normal. So the general surgeon wanted to do a mastectomy. So along with the radical mastectomy, I did a exenteration. This is the exenterated specimen. This is the radical mastectomy specimen with the lymph nodes. Multiple tumors developed on the forearms and the thigh in the early postoperative period within a weekday's time, which were again removed by the pathologist. And the excised specimens were and histopathology was malignant schwannoma, and the patient passed there within 2 weeks. In every case, do refraction for 2 reasons: because the orbital tumors can induce refractive errors, and unilateral hypermyopia can cause pseudoproptosis. Examine the color vision to know if there is optic nerve involvement. So this is how you evaluate a case of proptosis. So for a case of proptosis, you look whether it is a pulsatile or non-pulsatile. If it is pulsatile, it is a vascular pulsation or transmitted pulsation. If it is non-pulsatile, you look at the onset, whether it's acute, subacute, or chronic, and you know the various causes. And look at the direction of displacement. Is it axial proptosis or eccentric? If it is eccentric, depending on which peripheral surgical space is involved, you know the probable causes, and you can come to a diagnosis depending on whether it's acute pathology or a subacute or a chronic pathology, depending on. So the features of malignancy are short duration, usually less than 6 months is a short duration, or sudden change in the behavior of a long-standing lesion, motility restriction, pain, and CT scan showing non-discrete margins or infiltrating borders and bony erosions. They point out towards a malignant lesion. Features are suggested. So thank you all. for your attention. And if this is any questions? No questions. One question is there. So what's the question? Okay, there is one question. In proptosis due to cysticercosis, should the albendazole and oral steroids should be started at the same time or one after another with a gap? This is a question, a nice one. Question from Divya. Okay, thank you. In cysticercosis, even before we start the management, as I said, it comes with pain and infiltrative symptoms and motility restriction, congestion, and everything. So already there is an inflammation. When we put the patient on drugs that kill the cysticercosis, as it is dying, it releases toxins and the inflammation gets worse. So the purpose of steroids is to reduce inflammation. So we don't want the inflammation to get worse. So we do not want to give any gap between the starting of albendazole and the starting of steroids. Where we both start at the same time, the dose of albendazole is 15 milligrams per kg body weight in 2 divided doses. And albendazole usually comes as a tablet of 400 milligrams. In an adult, usually it is about 1 tablet BD, that's the dose. Whereas the amount of, that is for 4 weeks. Whereas the amount of prednisolone that we give is 1 to 2 milligrams per kg body weight. How much prednisolone I give depends on how much is the inflammation at the beginning. If the inflammation is mild, as in some of the cases that I have shown where the motility restriction, there is a minimum congestion, not much of proptosis. In those situations, I'll start with 1 milligram per kg body weight, which may be 40 to 50 milligrams to start with. And we'll taper it down over a period of 1 month and stop it along with the albendazole. If the inflammation is severe, in some of the cases where I have shown with severe edema, total proptosis, and with the total severe doses and proptosis and all those conditions, I'll start with 2 milligrams per kg body weight and again taper it down within 1 month. So we always start albendazole and steroids together, run for 4 weeks, the steroids tapering within 4 weeks and stopping at the end of 4 weeks. Am I clear? I hope. Any other question?
No, sir, that's
No.
all, sir.
Okay, thank you.
Thank you, sir. Thank you very much for the wonderful session on proptosis, sir. It's very useful for the postgraduates as well as the general ophthalmologists, sir.
Thank you. So if it is, there is no more question, I think we can close this now.
Yeah, yes, sir.
Right,
We can
we can.
conclude the sessions.
Thank you all. Thanks for all those who have listened to me. Thank you.
Thank you so much.
Bye. Close this.